Okay, good morning, everyone. My name is Nina. I'm one of the sleep fellows, and today I'll be talking about sleep disturbances in autism spectrum disorder. So no financial disclosures, but I will be discussing off-label uses of medications for sleep in people with autism disorder, including pediatrics. All right, and these are the objectives. And so let's start off with kind of what exactly is autism spectrum disorder, also known as ASD. And so based off the diagnostic criteria in DSM-5, there are four major core symptoms that have to be present in order to have a diagnosis. So that would be some type of deficit in social communication and interaction with others. So a lot of times we typically think of autism with this is the lack of interest in social communication, lack of interest in interaction. But it can also present as an overly odd or inappropriate way of communicating too, like too much reaction can also be part of this. There's also very restricted interest, as well as repetitive behaviors that we call stereotypies. There's also rigidity of thought, which means that folks with autism tend to think in black and white. There's really not a lot of gray. Historically, they tend to be rule followers. They may not be your rules or the appropriate rules, but they tend to follow rules that they instill for themselves. And then finally, this was a newer addition to the DSM-5, but hyper or hypo-reactivity to sensory input. So these are kids that either parents say they have a very high pain tolerance, or even just taking a shower and feeling the water hit them causes pain for them. And then associated symptoms are things that are at increased risk and greater prevalence within the autism population. So for example, seizures, the general population has about less than 1% general risk for seizures, but in autism, that risk actually increases to 20 to 30% overall. Psychiatric comorbidities, I mean, we all well know that lots of people in the general population have this. So anxiety, depression, bipolar disorder, OCD, all of the above. But overwhelmingly in the autism population, 70 to 95% of individuals have at least one psychiatric comorbidity. As you increase the comorbidities, that number does go down a little bit, but even when you look at 3 or more mood disorders, we're looking at 24% of the population, so 1 out of every 4. In terms of sleep disorders, as we all know, typically developing people also have sleep disorders. But in terms of the prevalence, those with autism have about double the amount of prevalence. So 40 to 80% as compared to about 25 to 40 of the general population for typically developing children. And as we all know, sleep disorders, poor sleep quality affects all of the above as well. So in terms of the most common sleep disturbances reported in autism, far and away is insomnia. So both sleep onset and sleep maintenance compared to typically developing teens, peers. We're looking at 2 to 3 times more increased risk, increased prevalence. And then that includes, just poor sleep hygiene, sleep onset association disorder, bedtime resistance. And we'll talk a little bit more about how to deal with those in a bit. Circadian rhythm, sleep-wake disorders typically delay, kind of like our teenagers, or even just irregular sleep and wake disorders. And so one of the things that we do deal with a lot in this population is that children with autism tend to sleep significantly less than their typically developing peers. We'll talk about some hypotheses in a little bit about why that is. At the end of the day, we don't actually know why, but there's some working theories. Parasomnias, just like in typically developing peers, you have your non-REMs that happen in the first half of the night. Those are your night terrors, your sleepwalking with limited recollection and consciousness of the child. Obviously more concerned about dangers with sleepwalking, and parents tend to be pretty disturbed by this. And then you have your REM parasomnias in your second half. So these are your nightmares that end up into very disturbed awakenings, distressing awakenings. And then often this is triggered by stress. And a lot of times in the autism community, this is something simple as change in routine. Because remember, they have the rigidity of thought, so they love their routine. That really regulates them. And so even having a small change in routine, such as taking a different way to go to school, can trigger things like this, or increase their anxiety. That can also trigger more REM parasomnias. And so a lot of parents come into our clinic with children with autism, and they just assume that this is just how life is going to be now, that I'm going to have a child that cannot sleep forever, and it's going to cause me problems and cause problems for the rest of the family. And so the literature shows that children with autism, and specifically increased severity of sleep problems, so moderate to severe problems, have increased problems with daily activities such as language skills, their social interaction, their daytime behavior, so having more irritability, more emotional lability, dysregulation. And then a little less correlated based off the study in 2012, but reduced adaptive skills. And adaptive skills are those skills, that everyday skills that make us functional as people and allow us to get through life. What they have found in the study in 2000, I'm sorry?
Example of an adaptive skill.
An adaptive skill would be able, like, for example, using utensils, taking public transportation, counting money. So, and the study in 2015 found that improvement in the core symptoms, those 4 diagnostic symptoms that we talked about earlier, whether that's through social skills groups or applied behavioral analysis, which is really the only treatment for autism, that improvement in those core skills allows for improved sleep function. So there's a lot of bidirectionality in these issues. And so we think about this quite a bit in pediatrics with the child and parent are you sated questionnaire that we get. But you know, parents and the rest of the family are also affected by a child with autism poor sleep quality. And so multitudes of papers have shown this, that it reflects on poor familial sleep quality, poor familial daytime functioning because of their poor sleep quality. Parental depression rates are higher, especially maternal depression. Also strained familial relations. And this paper by Rose in 2012 actually discussed a term called hostile parenting, basically, that there's marital discord that can happen because of this. And then also, and pretty important in every day and age, is parental employment. You know, the fact that parents are either late for work, getting the child ready, getting them up, getting them to school, those sort of things, that their own financial safety is at risk. And so I adapted this from Beth Mallow's presentation. She's a sleep physician that specializes in autism research out of Vanderbilt. But it really shows that there's bidirectionality and kind of 3 major players that help explain why people with autism have these sleep disorders. So there's a biological component, a behavioral component, as well as a medical component that we all need to be taking a step back and looking at as a whole picture. And so we're going to start first with these are some of the hypotheses for the biological drivers of sleep disturbances in autism. So first off is genetics, and specifically their circadian relevant clock genes. They're called zygubers, which are external signals that our body and these genes use in order to tell us when it's time to go to sleep, when to be active. And this is, a lot of times there are mutation variants in people with autism. So an example of a zyguber would be the suprachiasmatic nucleus using light as a signal for being active. And so some of these genes, the PER genes, the NPA, MTNR genes, which are the melatonin receptors, this is not an all-inclusive list. This just happens to be a small portion. And we're going to talk a little bit more, and I'll show you some diagrams that have a lot more information on them. Another hypothesis that I find really interesting is the autonomic nervous system hyperarousal hypothesis. And this came out of compelling findings out of a paper of 2013 that where they looked at various body signals such as heart rate, pupillary dilation, to see how children with autism and their anxiety levels, how are they different from typically developing peers? And what they found was that these children with autism have a heightened level of anxiety even at rest. So they have a lot of sympathetic over arousal all the time, which is interesting because there are some neurological physical exam findings that you can do to kind of see that being able to control sympathetic overflow is part of the natural progression of a maturing brain. And so certain neurological findings you would find that would signal sympathetic over arousal or overflow would be mirroring when you're doing finger to thumb. So typically that goes away in children about 8. In children with autism as well as ADHD, because it's a similar hypothesis that goes on there, that actually doesn't happen till a later age. So sometimes you will see 10 or 11-year-olds still doing mirroring with finger to thumb. And what you would do is you would have them do that, but you look at the opposite hand and see if they're mirroring at the same time. The other thing they found is that when you have a task that induces a lot of anxiety, for example, giving a talk in the morning, your body should be using your parasympathetic system and actually engaging that to calm you down so you can actually do mental tasks or any type of task at hand. What they found is that these kids have under arousal of the parasympathetic system. So their body doesn't have as much of an ability to calm them down. Also contributing to a heightened level of anxiety all the time. And then there were imaging studies, functional imaging studies that found amygdala differences, specifically volume increase early in life that regulates later and slows down in terms of growth as they age. And they found that amygdala enlargement is associated with increased anxiety symptom severity in autism.
Closely or sort of like population wise or what?
Well,
I mean, was it big studies, little studies?
these are not very large studies. They're underpowered. And another thing I was going to get to, because I'm going to talk a little bit more about melatonin and some of the findings there. But a thing that I do want everyone to realize is that these studies, especially functional MRIs or involving blood levels, things like that, typically those studies are underpowered, and they're also only on a subset of the autism population, specifically those that are considered high functioning or traditionally called Asperger's. Why? Because they're better able to deal and complete the rigors of a study. So a lot of times very low functioning children, patients are excluded because you have different things that can actually impact how you're interpreting the information. So such as level of intellectual disability, those sort of things. That answer your question?
Mm-hmm.
Okay. So this is a diagram. I actually really like this quite a bit, but it actually kind of maps out all the genetic variants that we know of currently that affect sleep regulation in patients with autism. And so, you know, the pineal gland, we know that that's in charge of melatonin. And so the MTNR genes are actually located in that area. All right, and this is actually a chart that I actually also really like from the same paper, but really lists all the gene mutations that we know currently. What mechanisms do they have in the brain with our neurons? How does that translate to sleep phase abnormalities that we see in children with autism? All right, and so here's a huge, confusing load of information, but we know that there are differences in melatonin processing in the autism population. What we do with that information, no one really knows. So I'm going to take you a walk through the historical context of these findings. So the first thing is, where does melatonin come from? It's an endogenous hormone that we make in our brains and a lot of cells actually, but it's synthesized originally from serotonin, which is in turn synthesized from tryptophan. And so when we're developing, first off, melatonin can cross the blood-brain barrier, and it can cross the placenta as well. And the thought is during neurodevelopment in the fetal stage that it promotes neurodevelopment by being neuroprotective in terms of facilitating neuroplasticity. Serotonin extensions and pathways are very much concentrated in the limbic cortex. So that's where your emotions are controlled, your social behavior is controlled. And to a lesser extent, the cerebellum, and which is in charge for attention regulation as well as your motor control. And the reason why this is important is because studies have found over and over, even from the turn of the century, 1999, that patients with autism have impaired brain synthesis of serotonin. They have lower brain levels of serotonin. A lot of this was, postmortem studies that have been done. And then other things that support this is that if you purposefully deplete tryptophan in patients in this population, that's actually associated with worsening repetitive behavior. The first biomarker that was considered, in which it's known, but nobody uses it, was actually discovered back in 1961, and it's called platelet hyperserotonemia. And so what we find is exactly what it sounds like. There's a gene called SERT that we talked about a little lower, but it's concentrated on platelet membrane. And so it allows the platelets to increase serotonin uptake, which means when you draw blood and check serotonin levels, there's actually increased circulating serotonin in patients with autism. And so we call that an endophenotype. How useful is it? It's not really useful. We know that it's a phenomenon, and there's nothing to do about it, really, honestly. But we can infer potentially some hypotheses on why people with autism have the signs and symptoms that they have. And so when they did functional MRIs on patients, again, these are Asperger's patients, low-powered studies, they found that when you look at serotonin receptor binding in the brain, patients with autism have decreased receptor binding for serotonin. And the degree of that was associated with abnormal social communication skills. Another thing, and this is specifically for boys with autism, not women, females, they for some reason didn't find this association. But the SERT gene, not only is it on platelet membranes, but also in the brain, if you have low expression of this gene, it's associated with increased brain volume. Why is that important? Just like we talked about the amygdala being larger in young years, one of the signs that we see on physical exam for especially young children with autism, like we're talking about 2-3 years old, is that they have a tendency to be associated with macrocephaly that ends up regulating over time and normalizing. And so this increased brain volume is thought to be tied with that. A bit about melatonin just in general, and it kind of ties into why it is recommended partially. In the perioperative world, surgeons have looked at the fact that melatonin can be used as an anxiolytic as well as an analgesic, and it works on multisystemic issues. So neuropathy, fibromyalgia, IBS, functional abdominal pain, that sort of thing. And the fact that it actually decreases hyperarousal. And how does it do that? So it inhibits the adrenal release of ACTH and all of its subsequent hormones that can contribute to arousal, such as cortisol, all your stress hormones, that sort of thing. And so the fact is, we know that people with autism have significantly less melatonin, specifically nocturnal melatonin. Interestingly enough, it's kind of a paradox, but daytime melatonin is actually elevated. And so what they think this is related to is potentially when you give exogenous melatonin, could there be some loss of effect? Could there be buildup of tolerance? And so that is thought to be associated with this potentially. And so a little bit more about the melatonin receptor. So MT1 functions almost like as a hypnotic receptor. It inhibits wakefulness by suppressing neuronal firing. So it's actually more responsible for your REM sleep stage. And MT2 is called a chronobiotic. It helps synchronize your circadian rhythm. And how does it do that? It makes your phase shifts between sleep and wake more efficient. And so that is actually associated with more of your non-REM sleep stages. All right, so a quick run through of just proposed pathways of how do you assess for sleep difficulties in autism. So making sure you're giving the family a lot of education, which can look a little bit different for those with autism. Are there any medical causes that could be contributing to this that we'll talk about a little bit later, including sleep disordered breathing, GI issues? Do you need to send them to a sleep specialist? Do you need to start a medication? And the important thing is medication should really be kind of your last resort. Although in reality, logistically, with wait times and things like that, depending on how severe it is, realistically, it may be more worthwhile to start something as you're waiting for, say, CBTI or the sleep medicine specialist as well. And so on the right, I actually have just a general overview of the most common sleep questionnaires that are used for pediatrics. So far and away, the Children's Sleep Habits Questionnaire, the CSHQ is commonly used, kind of looks at just bedtime resistance, anxiety, parasomnia, daytime sleepiness. There's also the Composite Sleep Disturbance Index that really looks over the previous month. So kind of accurately what is happening currently. There's a family inventory of sleep habits. This really just talks about sleep hygiene. I don't know of too many people that use it, to be honest. And then there's a pediatric sleep questionnaire that talks about sleep disordered breathing and possibly restless leg, periodic limb movements. But is there a better way? And so the CSHQ was actually modified to make a shorter version that actually is more specific for the autism community. So the original CSHQ had 45 questions. And the problem with it is when you have younger children, 2 to 5, that are, delayed in some way with autism potentially, it may over-identify sleep problems in those children with autism. And so the modified version has 23 questions. It's a lot faster. So those of us that are familiar with the developmental behavioral world, these parents fill out at least 400 questions every visit. So limiting the questions is better for them. And overall, it performed a little better than the CSHQ. In terms of sensitivity, when we're talking about moderate and high sensitivity, it was able to correctly detect those with sleep problems. But when you compare this to the original CSHQ, it was slightly less likely to do this adequately. But when we talk about specificity, this is where it really shines. It has moderate specificity. And the beauty of this is correctly able to rule out those without sleeping problems, especially in that 2 to 5-year-old age. So you're more likely to avoid false positives and intervene in a different way, potentially. And so on the left, this is a table that talks about the sensitivity, specificity, and PPV and PV, as well as the new cutoffs based off this new modified questionnaire. And then I'm going to quickly go through this for sake of time, but what do we do in these situations? So the first things first, behavioral strategies, realistically, before we start medications, although, in real life, that may not work. Bedtime resistance, so extinction, whether it's graduated or just basic extinction that's quick in 3 days. Biggest thing to tell these families is that they need to expect the extinction burst. Set them up for success, because when you don't set them up for success, parents backtrack and you have to start all over again. Using a bedtime pass if they're old enough, using a visual schedule for bedtime routines. A lot of times we use social stories and visual routines in order to convey the sense of scheduling, the sense of routine, expectations, and to expect consistency, which also helps with anxiety levels. Insomnia, relaxation, restricted time in bed, delayed sleep phase, so bedtime fading, light exposure therapy. Parasomnia, so typically if we're talking about night terrors, so scheduling awakenings. If we're talking about sleepwalking, making sure the house is safe, that they're not gonna, fall downstairs or get outside, anything like that. Sleep onset association disorder, so mostly stimulus fading for the most part. And a lot of times this is just parents being right next to them or in bed with them before them to fall asleep. So, we also do a gradual extinction type of method with that as well. They call it camping out sometimes. And then for everybody, sleep hygiene and using positive routines, which means creating a bedtime routine that is short enough, that is just not carrying on and is expected. And so on the left-hand side, so this is from the Autism Speaks Autism Treatment Network toolkit. They have excellent toolkits for younger children with autism, as well as teenagers with autism, specifically regarding sleep, as well as a melatonin guide for questions for parents as well. And last but not least, and really kind of the first thing you do as a provider is don't forget the basics. So ruling out any medical concerns. So obviously snoring, OSA, sleep disordered breathing, any type of restless legs, type of history that could be consistent with that. GI, so some papers will say up to 50% of children with autism experience some type of comorbid GI issue, whether it's GERD. So this is the kid that from baby age could not sleep through the night. Is there acid reflux concerns? Constipation is a huge concern because of sensory issues, as well as anxiety of going. So a lot of kids will hold it over time, and this ends up becoming encopresis as well. So, these are kids that will wake up with stomach pain. So getting a history about positioning when they're uncomfortable at night can be helpful. Are they having bowel movements in their sleep because of encopresis? Seizures. So are these night awakenings, are they accompanied by the same repetitive behavior? Is it a stereotypy that we should be concerned about in seizure disorders, thyroid disorders, vitamin D deficiency, any acute illness, even like an ear infection, and then medication. So ADHD stimulants, are they being timed appropriately? When when does it wear off in relation to sleep? And then activating SSRIs, anti-anxiety meds that could just simply be retimed for the morning. And then finally, medications. So if behavior and coexisting conditions are addressed first. So most important is there are no FDA approved medications for pediatric insomnia. That said, the largest body of evidence specifically in the autism community is synthetic melatonin. So if you look at the American Academy of Neurology, they have published practice guidelines for treatment of insomnia in children with autism, and this is a level B recommendation. The caveat is that it's best if prescribed from a pharmacy or is a high purity pharmaceutical grade. That's ideal. I always try to prescribe it if I can, but I tell parents, if it's a crazy copay or they're not going to cover it, just get it over the counter. That's the best we can do, unfortunately. So in terms of what it helps, so improving sleep latency. So that's specifically if you're looking at immediate release dosing, which half-life is about 40 minutes or so. Typically you administer this 30 minutes before bedtime as a hypnotic. And you're starting from anywhere from 1 to 5 milligrams all the way up to 10 milligrams. There are some cases where you may go up to 12, specifically some genetic disorders. But for the most part, my general rule of thumb is if you're going up to 10 and it's not doing anything, don't use it anymore. Then there's improved sleep maintenance, and this is more so with the extended release or controlled release versions. And so half-life typically is around 90 minutes, depends on the formulation, but you typically administer this an hour and a half before bedtime. And the purpose of that is over 8 to 10 hours while you're sleeping, it's going to mimic the endogenous melatonin release and have that peak at nighttime. And that's what it's supposed to replicate. And so typically you start 2 to 5 milligrams up to 10 milligrams as well for this. And generally the guidelines say you start off with lower doses and then you can go up to higher doses as you need to. And then in terms of risk, I get these questions all the time from parents because of a lot of the social media contacts that have come up. But adverse effects, so the important thing is there's no real long-term data that substantiates this, and they're pretty rare. So some morning drowsiness, increased enuresis, headache, dizziness, diarrhea, rash, hypothermia in very rare cases. But overall, it's incredibly safe to use at lower doses. In fact, in the NICU world, we actually use it as neuroprotection because it helps stimulate neuroplasticity in those patients. And then potential long-term adverse effects, again, no data, but potentially because you're acting on the adrenal glands, we talked about how it decreases hyperarousal, you could have suppression of the HPA axis and feedback loops, and that could potentially propagate or induce precocious puberty. There's also a risk of potentially increased prolactin because of the HPA axis feedback loops being disrupted.
That's associated with precocious puberty too.
So, yeah.
It's associated with precocious puberty, increased prolactin at age 8, 9, 10. It predicts when you have puberty. So
Yes, sir.
even in people without.
And then other medications. So these are all medications there's not a ton of studies on. Probably the most evidence out of this is for the alpha agonist, specifically clonidine, because that helps improve sleep latency, improve sleep duration as well. Questionable maintenance. There's some studies that support it. Anecdotally, though, I find that clonidine, it helps with sleep onset, but you tend to have awakenings. And at that point, what you would do is redose again at the awakening if they have at least 4 hours of sleep, usually at a lower dose. But the big thing to watch out for with these is daytime sedation, any hypotension, and the fact is it affects blood pressure. And so it needs to be weaned off. And a lot of times we use this with comorbid impulsivity and ADHD as well. And so parents also, they get kind of scared about these type of medications, but they're pretty safe medications. We just have to check blood pressure. They do need to come into the office, and we're going to titrate slowly. Okay. And oftentimes for ADHD, we give this throughout the day as well to help. Guanfacine works very similarly, a little bit of different dosing. I didn't put it on here because it's weight-based. Specifically, mirtazapine is an antidepressant. Interesting because there's some kind of paradoxical side effects with this. So at low doses, so we're talking about 7.5, 15, it tends to be more sedating, and there's an association with weight gain, which in children can be helpful in those with autism, especially if they have very restrictive eating habits to where they have malnutrition, they're not gaining weight appropriately. On the other end of the spectrum, you have those children with autism that are so selective that they all only eat beige foods, and there's a risk of obesity. So those are just kind of the thoughts. Very low dose 3.5 is actually more weight neutral, based off some of the studies. These are adult studies, not pediatric studies. Clonazepam.
Mirtazapine is a dirty drug, and at low doses is really an antihistamine.
Mm-hmm. I found it helpful potentially for kids that have malnutrition, they don't eat enough, and cyproheptadine or periactin, the other name, does not work, because I find that periactin is either a hit or miss. It either does work really well, pretty quickly, or it just doesn't work. Mirtazapine, especially if you have comorbid insomnia and anxiety, can be helpful. Clonazepam. Benzo, obviously it decreases arousal threshold, so it's helpful with the parasomnias, but the caution, of course, just like in every other population, is if there's comorbid OSA, you want to be careful about using this. So talking about 0.25 to 0.5 milligrams nightly. Other medications include trazodone, which we use a lot in the adult world. We use it in the pediatric world too. Doxepin is a tricyclic antidepressant that can also be helpful. A lot of these medications can be compounded. Risperdal, as well as all the other antipsychotics, are also used, especially if you have comorbid aggression, aggressive behavior, and a lot of dysregulation with these patients. And that's more of the, tends to be more of the lower functioning autism population. And then melatonin receptor agonists. I bring this up because, you know, these are interesting drugs. And so you have Ramelteon, and none of these, again, none of these are FDA approved for people under 18, but Ramelteon is FDA approved for 18 and above for delayed sleep, circadian rhythm disorders. And tasimelteon is interesting because it's specifically FDA approved for non-24-hour sleep-wake disorder, as well as Smith-Magenis syndrome. And so we know there's a lot of genetic syndromes that have an overlay with autism spectrum disorder as well. All right, audience question. So you have a 5-year-old boy. He sees you in sleep medicine because he was referred for his pediatrician for sleep difficulties. Parents are concerned about his intellectual development because he tends to be quote unquote quiet around peers, and he has zero interest in interacting with others. He is fanatical about the Titanic. Will tell you, just recite documentary facts to you in your office. He carries a toy boat with him everywhere. He often talks to it. He holds it to sleep. He'll play with it for hours. If things aren't done his way, he often has an explosive meltdown, including banging head on the floor. No overall concerns, overt concerns for anxiety, inattention, impulsivity, or hyperactivity otherwise. This is a very ideal patient. Parents say it's difficult for him to fall asleep despite working with an online sleep psychologist for the last 9 months. They've optimized his bedtime routine by shortening it. They made his room more conducive to sleep, so he enjoys it, calming activities before bed, and limiting screen time 2 hours before bed. He often wakes up too early for parents at 4 a.m. They would like to sleep in until about 6 or 7. And he's full of energy all day, even though the parents really struggle to get him to sleep by midnight. He does not snore, he does not nap. So other than continuing CBTI, what else would you consider to help with sleep?
I usually it's going and getting back melatonin, we try this one.
Which one? A, B, C, or D?
Yeah, which one?
Today for now.
I'll go with B.
Yeah, so this is B, and I like to add the extended release. Also, if you prescribe it, it would be called melatonin CR, controlled release, because a lot of these formulations now tend to be biphasic, meaning that they have an immediate release component as well as the extended release component. So potentially could help this child with both the sleep onset and sleep maintenance issue.
Because of 4 a.m. wake up, we're choosing an extended release, or
Say that again.
so why would we choose an extended release? Because he wakes up at 4 a.m.
4.
Yeah, because he only sleeps for a very short amount.
Yeah.
Yeah.
Both of the new ones
Mhm.
are both receptor antagonists, M1 and M2. Are there any selective antagonists, you know, M1 and M2 that are being in trials? People tried that?
I don't know how.
Okay.
The problem with it is that the fact that, you know, what is melatonin used in studies are pharmaceutical grade,
Right,
and that does not translate to what parents get over the counter.
right.
And so it's very difficult, I found, when I was looking at the melatonin studies, is how do you regulate and how do you exclude factors, which often means they have to have grants to obtain this type of medicine and have it put, yeah, so it's complicated. So I'm not sure of studies that have specifically looked at that, more so on like the melatonin receptor agonists, that sort
It's
of.
been looked at in animals.
More question here. So no concerns for anxiety, inattention, impulsivity, or hyperactivity otherwise. So they put that in there specifically to kind of steer you away from quarantine, because that's like.
Yes.
People go there.
So this child has autism, and you know, there's no concerns for anxiety and attention. You're never going to see that in real life. This is a question. Yeah, you're never going to see that in real life. So in real life, you're always going to have to take a step back and say, you know, is this insomnia, anxiety related? Is this more routine? Which a lot of these is a sensory. A lot of these have to do with a level of anxiety innately. And so answering that question first, dealing with it first, may be the way to deal with the insomnia as well. And so you kind of have to think of it as a it's it's all of it's bidirectional, and feeds into each other. Also, another thing that I find really important is how are parents? What is parents' mental health like? Are they anxious too? Because you'll have these parents, maybe their child with autism only sleeps 5 hours, but they function fine, okay? Do they wake them up? Sometimes they do, or maybe, are we using a color changing clock? Or can they play quietly in their room until it's time to get up and wake up parents? Setting expectations for these families, that to know that there is a level of discomfort that they kind of have to deal with as we slowly work through this and regulate your child's sleep. Okay, that's hard because in today's world, we live in immediate gratification all the time. People want a pill, a shot, something to fix something quickly. And I always have to, talk parents kind of off that ledge that you have to sit with this for a little while. You give them one thing to work on. And then at the next visit, you work on something else, and then hopefully they can get into CBTI. Access is always a question, always an issue, no matter where you go. What can they work on in the meantime until we get there? And like I said before, guidelines say behavior first, comorbid things first, and then medication. In reality, we're going to do behavior and potentially medication at the same time. Any questions?